Wonderful. We are live. Good afternoon, everyone. We are thrilled to welcome everyone who is watching this live and those who will be streaming this or watching this later to our exclusive interview/virtual event with Dr. Donald Thomas Jr., renowned rheumatologist and author of the lupus community's favorite lupus manual, the Lupus Encyclopedia. My name is Kelly, and I am the creator and I'm the executive director of the Portland-based lupus nonprofit More Than Lupus. And if you're unfamiliar with More Than Lupus, we are a multi-ethnic, multi-generational, and international lupus community designed by lupus patients to connect and grow and inspire each other throughout the peaks and the valleys of our lupus journey. And I say are because I have lived with lupus since the age of 11. So today's special event will really be a conversation. We are very excited to begin today with some exclusive insights and updates from Dr. T regarding his new edition of the Lupus Encyclopedia. And following that discussion, then we'll dive into the pre-submitted questions, and hopefully time will permit us to address any questions that are posted here in the comments as well. So since time is of the essence, let's dive right into our disclaimer, and then I'll introduce our special guest. So listen up, please. Please understand that the opinions shared today are purely for informational purposes and do not replace the medical advice and or opinions of your doctor. If you are experiencing lupus or lupus overlap symptoms, it's important to follow up with your doctor and to seek treatment that is best for you. Dr. Thomas is a qualified medical professional whose comments are based on years in the medical field. However, he is not liable for his comments today since he is not acting as your personal medical provider and does not know the nuances of your medical history. Now, Dr. Thomas is a rheumatologist who has specialized in the treatment of lupus for over 25 years. He has served as an assistant professor of medicine at the Walter Reed National Military Medical Center, as chair of the Medical and Scientific Advisory Council at the Lupus Foundation of America, chair-elect of the National Board of Sjogren's Foundation, and as a research consultant for the National Institutes of Health. Dr. Thomas is warmly known in the lupus patient realm for writing the best-selling patient handbook, the Lupus Encyclopedia, which, due to its popularity, will have a second edition coming soon. Having treated over 200 patients in his career, patients love Dr. Thomas for his investment into their well-being and his incredibly accessible manner. So thank you and welcome, Dr. Thomas.
Thank you. I'm very glad to be here today, Kelly.
We are thrilled to have you, and inquiring minds want to know, when can we get our hands on the second edition of the Lupus Encyclopedia?
Now, the quick answer is hopefully next fall, and that just shows you how long it takes to produce a book. I just handed in the manuscript to Johns Hopkins Press, and there's a lot of steps after that, believe it or not, to actually get it into print form. But I'm very excited about this new edition because there's a lot of new, great information that's practical, useful, and I got the help of 52 worldwide experts to help with each chapter, and many big names in the lupus field. So I'm really excited about this new edition.
That is so exciting, and how wonderful to have so many experts also collaborate on this second edition as well. Now, what are some of the biggest discoveries that have taken place since the first book was published that we might expect to see added into this new edition?
Sure, and I'll make that simple by telling you what new things I added. Number one, I got a lot of feedback, which I asked for with the first edition, where people could email me their recommendations for the second edition. I did read those, and I put most of them into effect. One of them was to include rare complications that I did not put in the first edition because they were rare. I didn't think that they'd be applicable to most people. And certainly when you look at one rare complication, very few people are going to have it. But when you look at a bunch of lupus patients, a a lot of them are going to have rare complications, so it makes sense. So it's going to include those rare complications. If you have it, you can look it up in the index and read about it, which is a really nice thing. It's going to be applicable to those patients. There's been better and more accurate ways to diagnose lupus than 10 years ago. We've now identified close to 150 genes that predispose people to causing lupus. We're going to talk about the leaky gut syndrome and the importance of the microbiome, which is the bacteria inside the intestines which interact with the immune system, and how important eating a diet rich in probiotics, prebiotics, and the anti-inflammatory diet is. We'll have an updated pregnancy and breastfeeding section. We'll have a new chapter about prognosis and healthcare disparities, which is, as we know, in the past year is such an important problem in the United States and the world and in lupus itself. There's a whole new chapter about pediatric lupus. I unfortunately did not discuss much on pediatric lupus. And now with the first FDA-approved drug for pediatric lupus in 2019, it's even more applicable. Also, I'll talk about what to do with your drugs around vaccines. It talks about systemic lupus, of course, and its interaction with COVID-19. There's a lot new information about the dosing of hydroxychloroquine has changed since the first edition. Newer and better eye screening test recommendations. We have 2 brand new drugs for lupus: Volcosporin, which is leukinase for lupus nephritis, and just on August the 2nd, anifrolumab, which is Saphnelo, was FDA approved to treat systemic lupus. I've expanded the chapters on complementary medicine and non-drug treatments. I had the help of some great integrative medicine doctors who specialize in rheumatology who helped out with those. And we'll talk about medical marijuana, CBD, and the list goes on and on.
Wow, that is incredible. I'm just changing the format here because someone told me that part of your face was cut off. So hopefully this is a little bit better. Oh goodness, that is amazing. Now, one of my favorite sections of your book was the section on your anti-nuclear antibody. And any new additions or changes since 10 years ago with that we might expect in the book?
Yes, actually a couple of important things. Number one, it was shown in several studies that we've always looked at immunofluorescence anti-nuclear antibody testing to be the gold standard. But recent studies have shown, especially by Dr. Pazetsky, who's a world-renowned lupus expert, that the immunofluorescence methodology checking for anti-nuclear antibody is flawed in many laboratories, and people can be negative for this particular ANA test. So it's not as gold standard as we thought it was, and it's probably important to check more than one anti-nuclear antibody test in many patients who may have systemic lupus. So that's number one. Number two, we used to say that once you're ANA positive, it never needs to be checked again. But recent studies show that when someone with systemic lupus becomes ANA negative, that shows that they're at less risk of flaring. And so it's a good sign for prognosis. So we actually can and should repeat it in our patients, because it does help give someone peace of mind, especially if it becomes negative. So that's important.
That is really fascinating. So less chance of flaring, but they still have lupus. Yes. Yeah. So that's the hard part, is when someone changes doctors or physicians and moves, and ANA is negative, and then that diagnosis gets questioned.
And let me just remind people, please keep records of all your medical records to include your laboratory tests. I've had patients who have become negative for ANA who then had to go to other doctors because of insurance changes or moving. Then their ANA was negative. They were told they probably don't have lupus. Their medicines were stopped, and they had severe flares. So please, in fact, one of my patients had a severe stroke. So please keep copies of all your records to include your original lab tests and protect yourself.
Yes, absolutely. I speak for a very large community of lupus patients when I say we are waiting on pins and needles to get the new edition, and we can't wait. So it'll be a year, but we are patiently waiting for that. Well, let's keep rolling here and dive right into the pre-submitted questions. Of course, I'm not surprised to see the first several questions that came in are related to the pandemic and the vaccine. And the first question that we have for you, Dr. T, is why is it so important for lupus patients to be vaccinated?
Kelly, this is another change since the first edition of the book. Previously, cardiovascular events like heart attacks and strokes were the #1 cause of death in lupus patients. Now, in the past few studies, infections has overtaken heart attacks and strokes as the #1 cause of death. But guess what, Kelly? Most are completely preventable. So think about that. People can prevent the most common cause of death. It's all in their hands as far as what they can do. So it's just crazy not to get vaccinated. What I tell patients is that preventative medicine is always better than waiting for me to come to the intensive care unit and treat you while you're on a ventilator type of medicine. So I'd like to mention several vaccines in particular. The COVID vaccine. Studies show that lupus patients are twice as more likely to die than healthy people from COVID-19. That was shown to us by a United Kingdom study. So it's so important to get vaccinated against COVID. Number two, and also think about it, I know a lot of people out there don't believe in the COVID vaccine, Kelly, but think about it, how full our hospitals are right now of COVID patients. But guess what our hospitals are not full of? They're not full of people with side effects to the COVID vaccine. And I know here in our area, our hospitals are full of COVID sick patients. How about in your area, Kelly?
Yes, they are. In fact, yesterday when I was having my infusion, they were life-flighting people out of the hospital because there's simply no room. And unfortunately, the morgue is full as well with COVID patients. So it's pretty bad,
I'm sorry to hear that. It's pretty much the same here.
Mm-hmm. So should lupus patients who have already had COVID-19 still get vaccinated? That was another question that came in.
Yes. First of all, we don't know how much immunity lupus patients will invoke. That's currently being studied. For example, I'm sending a lot of my patients to the National Institutes of Health to enter a study that's actually trying to answer that question, but they probably don't invoke as much of a response as healthy people. And even in healthy people, we know that it starts to wear off after a few months. There was a study that came out in one of our major medical journals a few months ago, which actually looked at this in healthy people and showed that when previously infected people got the COVID-19 vaccine shots, they had a markedly increased response rate. And an infectious disease expert who wrote an editorial stated that healthy people who hadn't been infected need the vaccine and that they could actually become bulletproof. He used the word bulletproof against COVID-19. Of course, we probably don't expect bulletproofing in lupus patients, but it means that they're going to be much more likely to be immunized against COVID-19 compared to if they don't get the vaccine.
Wow, that is some pretty powerful words. And I hope that encourages people who feel that they are invincible because they've already had COVID to still get the vaccine. The next question that came in was, what are the chances of having a bad side effect from getting the vaccine, like a lupus flare or possibly a blood clot if you have APS?
Certainly. Well, first of all, they're very rare, Kelly. They made the news because they're newsworthy, because all eyes are upon the COVID-19, and any side effect is going to be reported on in the public. But just as a comparison, I'll state this: in America, there's over 400 people who die from penicillin every year. Over 400. Yet none of my patients would refuse me to give them penicillin for an infection if they've never been allergic to penicillin before. Well, with COVID-19 vaccinations, blood clots and complications like myocarditis are significantly less likely to happen from the COVID vaccine compared to death from penicillin. People can expect some side effects such as flu-like syndrome, which actually usually means the immune system is mounting a good response, which is what we want to happen. Personally, I ask my patients to take Tylenol around the clock for a few days after their vaccine to decrease the chances of that happening. But please don't do that unless you ask your doctor first. And then a recent study just came out this past month in one of our major medical journals. They actually compared a large number of healthy people to lupus patients and other autoimmune disease patients and showed that there was no difference in the number of side effects between the two groups. So all lupus patients should get the vaccine unless you've actually had an anaphylaxis or severe reaction to the vaccine. That's the only contraindication.
Mm-hmm. And if I recall, the last time we spoke about this, you have a shellfish allergy like I do, right? Yes. Yeah. So I remember that. So I take our EpiPens when we get the vaccine, and zero histamine response, zip, zero, zilch. So, but we do it just to be good. But there's a lot of people who have that fear. If I'm allergic, if I have a food allergy, this is going to be not beneficial for me. The other thing I loved what you said was, if you have those flu-like symptoms, if you have that mild fever and chills and headache and body aches, that's a good sign. And I get a lot of texts from lupus patients who got the vaccine and said, I don't feel good, I think I made a mistake. But it's a good sign that you have those flu-like symptoms, as it means your immune system is revving up for reacting to the vaccine. That's something that people feel they get backwards. They often think it's bad when they feel those things.
Yeah, and one good piece of evidence for that is that when you look at age groups and the response to the vaccine, it's the younger people who are much more likely to have side effects like fever, muscle and joint weakness. But people in their 60s, 70s, and 80s are much less likely, and it's probably because of their decreased immune response due to the aging immune system over time.
Interesting. Okay, I can continue to ask my own questions, but I'm gonna stick to the questions that came in here. The next question that was pre-submitted was, are you recommending the booster shot that's now available to immunosuppressed patients to your patients?
100%, and I'll just give a shout out to my own blog, if that's okay, Kelly. Well, I would, if you don't belong to my blog, go to lupusencyclopedia.com. And my latest post, I actually posted the results of the Moderna booster trial, and they did this in immunocompromised patients, so lupus patients. And in fact, most of the patients in that study were on mycophenolate, which is Cellcept, which is one of the most common drugs that we use to treat our lupus patients. So listen to these numbers. After the second Moderna shot, the average antibody response to the vaccine was 32, and this is looking at the spike protein, which is the most important one to measure after vaccinations. It jumped from 32 to over 1,200 after the booster shot. 32 after the second, over 1,200 after the booster. You just have to get your booster shot. So important.
Well, there you have it.
By the way, similar results with the Pfizer study.
Wow, incredible. A lot of people are asking, and this question came in, should you still wear a mask if you have lupus and you're fully vaccinated?
Kelly, I still wear my mask. religiously. I just see too many horror stories every single week. We just recently had an internal medicine doctor, one of our favorite and best, die from COVID-19, and I hear horror stories every single week from patients. So, I mean, this is a true and horrible thing, and so even I wear my mask, and I'm religious about wearing it. And just for example, we know that that even vaccinated people, even if they get infected with the Delta variant, they may not get as sick as other people, but they transmit it. And so it's my responsibility to protect those around me as much as it is for me to protect myself from someone who might not be vaccinated and might be around me. Also, you don't know what your response is after you're vaccinated with lupus. Unfortunately, a lot of our patients don't mount as good of a response as we would like them to, and so we need to wear it because we don't know that. Even if you had your spike antibody response measured, which a lot of our patients have, because it is available clinically now, and some patients are in research studies. The problem is we don't know what that number means. For example, the measurements I just mentioned, 32 versus 1200. What's the right number to be truly immune to the COVID-19? We don't know. This is such a new thing. Certainly the higher it is, the better it is, but we really don't know. And even if you know your number, you don't know how much that really protects you. And then also, even if you knew that number, your response probably is going to wane over time. We don't know how fast that's going to be. So those are reasons to do it. And also, just to mention, Kelly, everybody's heard in the news this past week, there's a new variant called the Mu variant from Colombia that appears to probably be or possibly be resistant to the vaccine. And now there's over 2,000 cases in the United States. So you have to protect yourself.
Yes. All right. So the next question that came in. And this, I'm sure, is going to heat up a lot of people. I know I've had moments where I was really upset about this. We're seeing this again. Last year, we dealt with the hydroxychloroquine shortage when it was temporarily approved for the emergency authorization through the FDA. Then it was retracted after finding that it didn't help with COVID-19. Now we're hearing about it being used again. And to add salt on the wound, the RA drug Actemra is being touted as a treatment. And patients are seeing national shortages with both drugs again. In your opinion, why are these rheumatological drugs being targeted as COVID treatments? Do you think they work? And how can us as patients get access to our essential medications?
Oh, Kelly, don't get me started. Hydroxychloroquine, an example of where the government trumped medical science. Forgive my pun. Anyways, thank goodness that the FDA retracted that. There have been multiple studies now showing that hydroxychloroquine absolutely does not decrease deaths and hospitalizations from COVID-19. Don't believe what you hear on the media with the false news that is out there right now. It doesn't help. However, the other drugs do, and the reason for that is that what happens with COVID-19 is that it increases immune system disease activity enough to where it actually looks like a lupus-like disease. Vasculitis-like disease where it attacks the blood vessels, and it's this inflammatory reaction that's the cause of death in a large percentage of patients. And so it makes sense that using medicines that calm down the immune system would probably help, and that's exactly what we're finding. And I'll just give you some examples. Dexamethasone, which is a type of steroid, has been shown to decrease deaths by 46% in patients with severe infection who are on ventilators. And so it has been used a lot in treating our patients. COVID-19 patients have been found to be high in a certain cytokine. Cytokines are chemical messages that white blood cells send to each other. It's how they talk to each other, basically. And interleukin 16, for example, let's say that one white blood cell sends out a whole bunch of interleukin-16. That interleukin-16 tells other white blood cells to become more active and attack the lungs and other parts of the person's body. We actually have medicines that decrease the interleukin-16 directly. One of those is tocilizumab, which is Actemra. Actemra is FDA approved to treat rheumatoid arthritis, and it's the only FDA-approved drug to treat some other diseases, such as something called giant cell arteritis, which causes blindness in older people. Well, it has been shown to be effective in COVID-19. People who take or are treated with Actemra while they're very, very sick with COVID have a 25% greater odds of not dying. And it's been shown in numerous studies. It's been the most studied medicine. And so it does have emergency use authorization from the FDA to be used in COVID-19. But now we have a horrible shortage. I have a lot of rheumatoid arthritis patients on this medication who I can't get it for them no matter what, because they're giving a preference to COVID-19 patients. And that makes sense because there's a lot more drugs for rheumatoid than there are for COVID-19. And why do we have this shortage? Why can't drug companies just make more? Well, it's because it's a biologic. It's much easier to make pills, which are made through chemical processes, than it is to make a biologic, which is made through living processes. For example, Actemra is produced genetically engineered inside of mice. You have to have mice and keep them healthy in a large factory in order to make Actemra, and you just can't automatically produce huger sterile factories to do that, and that's why we have a big shortage. Now, there are some other emergency use authorization drugs, by the way, Kelly. There's one called Olumiant, also called baricitinib, and Xeljanz, also called tocilizumab. And by the way, both of those have been shown to be effective and safe in lupus patients. Xeljanz passed the phase 1 clinical trial. Olumiant has passed phase 2 clinical trials. But both of them have been shown to significantly reduce COVID deaths. And so they're being used, but it's much easier to produce these because they're pills, and so we haven't had a shortage, thank goodness. There's a drug related to Actemra called Kevzara, which also interferes with interleukin-16, and it can also help as well. And so far, we don't have a shortage of that, thank goodness, but those are the reasons.
Are you finding you're having to switch your patients who are on Actemra to something else because they can't get it, or are you kind of in a holding period right now?
Right now, what we're trying to do is get them the subcutaneous form, which I suspect will be a problem because, for example, Medicare prefers intravenous Actemra, and it's the intravenous Actemra that's being used for COVID-19. And so when I try to put those patients on subcutaneous, all at once it's a lot more expensive for them as far as their co-pays. And so we're right at that stage right now, trying to get the subcutaneous form, and I don't know what's going to happen because this is such a new problem.
Right. Oh, wow. That is really interesting. And I had no idea that the molecules for Actemra were developed in mice. I did not know that. Gosh.
In fact, I went to
things I learned from you, I tell you.
Humira was one of the first biologics, and I'll never forget visiting the factory in Puerto Rico that produces Humira. Humira is produced by bacteria. And so you walk in there, you have to take off your clothes, put on sterile clothes, and sterilize yourself. Then you walk into another room, you sterilize yourself a second time, and then you go into the factory where there's huge vats of sterile bacteria producing it. And so I could see firsthand why these medications are so expensive. And you get one vat wrong or infected, that destroys a lot of medication. And so I could see why it's so hard to produce more Actemra.
Wow. Well, of course, my mind goes to all these other questions real quick, and then we'll move on. You know, Benlysta is a monoclonal antibody as well, biologic. How is that developed?
You know, I'm not 100% sure. This is most common when I prescribe. I don't even know. But it's going to be one of those ways, though.
As long as it's not puppies, I'm good.
Yeah, I'm sure it's not puppies or kitties.
Oh my gosh. Or murder hornets or something like that. Oh, wow. That is really fascinating. And I also find it really fascinating, this comparison of the immune response on some form with systemic lupus, with these overactive cytokines, interferons, and then with COVID, those overactive cytokines when it gets into that stage 2, the lung involvement and the pneumonia state. I think it's really interesting how there is some parallels there. And if we could help each other out without hurting each other and finding enough medication for everyone and understanding the nuances of each,
In fact, Kelly, one interesting thing is that the really sick patients, the ones with lung involvement and ventilated, most of them have blood clots, most. And most of those blood clots are due to antiphospholipid antibodies, the exact antibodies that we see in 1/3 of our lupus patients and that cause blood clots in our patients. So there is a lot of similarity.
I didn't know that. That is really fascinating. It'll be interesting to see how all the clinical trials that come out and these studies, they delve into layer after layer after layer about that and those connections there. That's really fascinating. Well, I could keep talking to you about my own questions, but I'm going to get back to the ones that came in. Okay, here's the next one. And this is a really authentic, I thought this was very authentic and vulnerable. This person sent this question to me on Facebook, and she said, I'm embarrassed to ask this very basic question since I've had lupus for many years, but I've never had it completely clear in my mind if SLE means that the entire body is in a constant state of inflammation, or does it mean only organs or certain systems are being affected or are inflamed and under attack?
Well, Kelly, I'm ex-military, and first I'll tell this person, there is no such thing as a dumb question, because I guarantee you there's other people watching this who have the same question as well. So we must assume that there's systemic inflammation when any organ of the body in lupus is active. And just one example is discoid lupus. We oftentimes separate discoid or skin lupus from systemic lupus. However, a recent study showed that patients who only have discoid lupus have a higher chance of heart attacks and strokes than healthy people. So that means that there's something going on systemically and not just in the organ itself. There has to be inflammation going on in the blood vessels, just like we see in systemic lupus. So that's something that's pretty new with that. So even if someone's feeling well and they just have one organ system that bothers them just a little bit, they have to assume they have systemic inflammation. And the bad thing about that is the heart attacks and strokes that can occur. And this is one reason why my goal and most lupus experts' goal is to get our patients into complete remission. Don't put up with flares, even if they're mild flares. For example, I'll get patients who will have once a month around their menstrual cycle, a flare or some mild joint pain and fatigue, and they'll just want to put up with it. Don't put up with that, because that means that you're having systemic inflammation and you don't know what damage that's doing to the blood vessels of your body and increasing your risk of heart attacks and strokes. One of the best studies we have so far as the importance of cutting down inflammation is from the Benlysta studies. They've been studying the original patients for a long time, and they released the 7-year data. And patients who have been on Benlysta for 7 years or more and had better disease control than what we usually get in our patients had significantly less organ damage compared to the standard of care treatments for Benlysta. What I mean by standard of care is the old treatments for lupus. So there's a lot of research being done in this, and bottom line is you want to try to work with your doctor to get yourself into remission or at least low disease activity.
Exactly. And also, don't stop your meds just because you're feeling okay.
Yeah.
They're working. That's why you're on them. Right. All right. The next question that came in from someone through Facebook as well. Can UCTD turn into lupus? What markers are needed to be detected and be diagnosed with lupus?
Sure. So first I'll define UCTD. UCTD stands for undifferentiated connective tissue disease. And first off, I'll say that it's a real disease. A lot of people will be diagnosed with UCTD and think that it's kind of limbo land and it's not something real, and the doctor is just saying it because they don't know what else to say. But what it means is that someone does have a systemic autoimmune disease, but it doesn't fit the classification criteria for one particular one. As human beings, we like to define things in very simple terms that make it easy for us to think of something. But systemic autoimmune diseases are not like that. They start off with diseases that just have some autoantibodies that can attack the body and maybe just give one symptom or problem, even just fatigue or just joint pain, all the way to something severe on the other side of the spectrum, such as systemic lupus attacking the kidneys and the brain, and that's incredibly deadly. Everybody else is way in between. So UCTD are the people way over here on the mildest form. So they have autoantibodies. They definitely have systemic inflammation, but they may have antibodies that are not specific for any one disease or help us diagnose at 100%, or they might have inflammatory arthritis and a positive ANA and nothing else, but it's definitely a systemic autoimmune disease. We know that about 10 to 20% of patients who have this will eventually develop systemic lupus erythematosus. And about a third of patients would evolve over time to develop one of the systemic autoimmune diseases, such as rheumatoid arthritis, Sjogren's disease, systemic lupus, polymyositis, etc. So the other part of this question is what markers help detect who's going to be turned into lupus. There are some things that help predict it more than others. Number one, if you are of African ancestry. Those UCTD patients who are of African ancestry have a much higher risk, and it's most likely because of the genetics. Number two, having hair loss. Number three, having pleurisy. If you have discoid lupus, it increases your risk. Having an antibody called Coombs antibody, having anti-double-stranded DNA antibodies, anti-Smith antibodies, and false positive syphilis tests. Those also predict it as well. We also know that if we give our patients hydroxychloroquine who have UCTD, it decreases their risk of evolving into a severe form of lupus. So I personally recommend hydroxychloroquine to my patients. I mean, how do we diagnose lupus? Is by classification criteria, and we have 3 different criteria we use these days.
Wow. Thank you for breaking that down for this person. I hope that if you're watching right now, that answered your question. And then here we go. We have a question about our new shiny penny. What do you think about the new drug Saphnelo for SLE? And then the follow-up question is, can I take it if I'm currently on Benlysta?
And I raise my hands because the last few years have been a miracle for lupus patients, Kelly. 2019, the first pediatric lupus drug became FDA approved, Benlysta. In December, Benlysta became the first FDA approved drug for lupus nephritis. And in February, January, Lupkynis became the second lupus nephritis FDA approved drug. And then just about a month ago, Saphnelo on August the 2nd became the second drug ever FDA approved to treat systemic lupus since 1957. Color television sets were just coming out in American homes. I was not even born yet. So it's a travesty until recently. And this shows, and guess what, Kelly? This is just the beginning, by the way. There's a lot of hope, and there's a lot more in the pipeline, and we're going to see more of these miracles coming out. So first disclosure, I am on the Speakers Bureau, and I'm a consultant for AstraZeneca, which produced Saphnelo, and GSK, which produces Benlysta. So I'll have to throw that out there, but I do that because these are just amazing medications. So first of all, Saphnelo is specifically designed for systemic lupus patients. Everything else other than Benlysta and Lupkynis were developed for other diseases, and they were just discovered accidentally that they can help lupus patients. That includes methotrexate, hydroxychloroquine, azathioprine. I could go down and down on the list. But in systemic lupus, we know that around 80% of patients with moderate to severe disease have very high levels of a cytokine. Again, remember, those are chemical messages that white blood cells send to each other, called type 1 interferon. And high levels of type 1 interferon are seen in patients who have higher disease activity. The way that Saphnelo works is that every white blood cell has binding sites called receptors for type 1 interferon, and Saphnelo binds to that and takes away the receptor, makes it go inside the cell so that the type 1 interferon can't bind to it and make that white blood cell active, so it doesn't become active and attack the person's own body. And that's basically how it works. And we know that this type 1 interferon is a major cause of lupus disease activity. So what the study showed is that when patients with systemic lupus, moderate to severe systemic lupus, were given Saphnelo, it was effective and safe. Especially those who had skin disease and joint disease were the driving force as far as what we saw. And again, people go to my website, lupusencyclopedia.com, and in the search bar, type in Saphnelo, and you'll see my articles about it. But one of them has a picture of a typical patient with severe skin lupus, and it just shows how she did. She had been failing other drugs for her systemic lupus, and you see where she went to horribly severe cutaneous skin lupus to almost clear it up. It just has amazing effects on a lot of patients, and that's just a miracle. And then the side effects were not very much. We saw some increased upper respiratory tract infections. There's definitely an increased risk of shingles, so you want to get your shingle shot done, but otherwise very safe. In all the trials for Saphnelo, there was only 2 cases of angioedema, which is a severe allergic reaction, but there was no anaphylaxis, which is the most severe type that me and you get to shellfish. There was none of that seen, for example. It's also the only lupus drug that is allowed to say that it has a steroid-sparing effect. How many of you love steroids and prednisone? Anyone? So what it means, steroid-sparing effect, means it greatly decreases the need for steroids in lupus patients. Think about that. That's just phenomenal. So currently, I have a lot of my patients, well, not a lot of them, most of my patients, thank goodness, are in remission or low disease activity. But I have patients who are not in remission, and I just have them waiting for Saphnelo because they have failed everything else. And so I can't wait, and my patients can't wait for this medication. However, it has not been studied in combination with Benlysta, so we don't recommend its use in combination. But I hope that someone studies it because, number one, they have 2 completely modes of action, and number 2, both of them have decreased side effects or a pretty low number of side effects, and the potential side effects that they seem to cause seem to be very different. So I hope someone does that study.
Yes, and all of us who are on Benlysta, it's very intriguing to wonder if possibly Benlysta isn't working as well as it needs to. You know, if we stop Benlysta, how long before we could start Saphnelo? Because I know sometimes it takes a while for it to get out of the system. That's been a question on my mind as well.
Yeah, we really don't know. This question was actually brought up to some of the experts who helped prove that Saphnelo was a good drug, some of the world's best lupus experts, and they didn't really know. I plan on starting my patients about a month after they stop their Benlysta medication. And that was a common answer given by the experts.
Good to know. And do we have an idea of when it might be readily available in clinics?
It's available now.
Right.
Air quotes right there.
Right.
I use that because insurance is the only barrier. And for example, it's all of bureaucracy. You love insurance because it helps patients get expensive medicines. You hate insurance because they put up barriers to things. So it's very hard to get any patient a new medicine. And just for example, they have to have a special code called a J code in order for Medicare to even cover it at all. And it's not going to get its J code until February. So we're afraid our Medicare patients may not be able to get it at all until February. I have 6 patients lined up to get it that we're fighting to get the medicine for them. Fortunately, one of them, I have been able to get it for them, and she's almost ready to start it. So it is here. If you have a commercial insurance, you can probably, hopefully, get it soon. But if you have Medicare, it may be February.
Right. And we are, as patients, we're very aware of the steps, the step therapy with insurance and having to try and fail certain medications before insurance will cover it. So hopefully that won't be an issue with this. The other good thing is I've heard is that it's a 30-minute infusion. So that's a lot shorter than Lista, which is, to me, I thought that was kind of a plus. It's pretty short, once a month infusion.
And it works fast too, Kelly. Most patients had an effect within 2 months. So that was really good. Mrs. Muzet, she says hello, everybody.
Hello. That's adorable. Wonderful. Well, since we're on the topic of new medications, a question came in about lupus. And this person knew the name sounded a little familiar to another medication, Volcosporin and Cyclosporine. And how are they different? And what are their mechanisms? And how does one treat lupus nephritis and the difference between the two?
Yes, or I have another full disclosure. I'm on the Speakers Bureau, and I'm consultant for Aurinia, which is the producer and maker of Lupus. But after I tell you the following facts, you'll see why. It's just an amazing medication. So Cyclosporin and Volcosporin, which is Lupus, are both types of medicines called calcineurin inhibitors. And there's a third one that we use in our lupus nephritis patients as well, called tacrolimus. And so how these work, and they have a fascinating way of working. Calcineurin is a chemical inside of cells that does bad things. Number one, when it's inside of T cells, which are a type of white blood cell, it causes the genes of the T cell to make bad inflammatory cytokines, those chemical messages that tell other white blood cells to attack the person's own body, to include the kidneys. So it increases inflammation. So when you give these calcineurin inhibitors, they bind to this calcineurin and inhibit it, keep it from working so the T cell doesn't attack the person's own body. So that's one good thing. The other thing, very fascinating, is that inside the kidneys, you have these cells called podocytes. Pod means foot in Greek. And so podocytes have feet. Think of them as Pac-Man. They look like Pac-Man, actually, when you look at them under electron microscopy. And then their feet come together and they make a sieve or a colander. And that's the filter of the kidney. On one side, you have the blood. On the other side, you have the urine. And so on the blood side, it's just allowing the waste products to go through that filter and go into the urine so you can pee it out. So let's say you get lupus nephritis. In lupus nephritis, those podocytes are damaged and the sieve gets larger, and very important parts of the blood, to include proteins, leak out into the urine. And that's how we can help diagnose lupus nephritis, by seeing that increased protein in your urine. Well, guess what? They get damaged because of calcineurin. And so calcineurin inhibitors stop that from happening. And in the person with lupus nephritis, the podocytes become healed and they work better and they filter the urine well. In fact, I've seen it work so amazingly that I had this one patient where her proteinuria was over 3,000. 200 is normal. And when she was normal, I took her off of her tacrolimus. 2 weeks later, it jumped to 3,000. I put her back on her tacrolimus. It went back down to 200. That's how amazing they work. So now I'll get back to your question. Sorry to get off track, but I think it's helpful to understand how these work. So cyclosporin is an old calcineurin inhibitor. Lots of side effects, but can work great in some patients. So what they did is they took cyclosporin, they added one carbon molecule that's double bonded to the most important part that binds to calcineurin. And since it binds more strongly, it works better, and you can get away with much lower doses than cyclosporin. So think about that. You can get this effective drug that you can use much lower doses. And so there's also less side effects with it. And it's so stable that you don't even have to measure drug levels, which with cyclosporin, you had to measure drug levels all the time. With cyclosporin, we had to worry about high cholesterol. Lupus doesn't do that. With tacrolimus, which is related to it, which can cause diabetes, we don't have to worry about that with this lupus. And so that's how good it is. So how good does it work? And this is one reason why I'm a huge proponent for it and why I work with the drug company. It's important for lupus nephritis patients to get completely into remission. And the reason for that is as follows. And if any of you have lupus nephritis watching this, this is important for you to hear. If you don't have lupus nephritis, you need to hear this, because if you have systemic lupus, you have a 45% to 50% chance of getting lupus nephritis. That's why we want that urine sample all the time. So if we get someone into a complete renal response or remission, 10 years later, 90% of those patients are still alive. This was shown by a study about 10 years ago. If they get a partial remission, just a partial response, let's call that a partial response, which is the vast majority of lupus nephritis patients. At 10 years, only 45% of them were still living. 45% versus 90%. So remission is so important. So in the lupus trials, when they compared lupus to standard of care, and standard of care is using either mycophenolate and high-dose steroids or cyclophosphamide plus high-dose steroids, that's how I would have treated all my patients 1 year ago. But now we have this new medicine called lupus. How much better does it work? When lupus was added on top of standard of care just a year ago, that person is 2.7 times more likely to have a complete renal response. Wow. That means they have a 170% greater odds of achieving a complete renal response. Plus, it worked twice as fast. And people of African ancestry, unfortunately, do much worse with lupus nephritis than other races. They were 3 times more likely to have a complete renal response. That's phenomenal. And again, you hate steroids, Kelly? In the study, the lupus trials, if you get lupus nephritis, most rheumatologists would still put you on 60 milligrams a day of prednisone. Horrible, right? In the lupus trials, they only used 20 to 25 milligrams of prednisone compared to 60. Plus, they got the patients down to 5 milligrams a day by 8 weeks, 2 months. That's just phenomenal. Kelly, the future is much brighter for lupus patients today, and this is one of them that's making a difference.
That's incredible. That is incredible. And it's a pill, right?
Yes, and can I tell you about something else? Just in the recent studies at the American College of Rheumatology meeting, they just showed the results of a medication called obinutuzumab. It's a drug we use to treat leukemia and lymphoma. It's called Gazyva. It had a markedly increased remission rate for lupus nephritis, and the side effects were significantly less than in those patients on placebo. So imagine that, Kelly, a strong drug for lupus that had much less side effects than placebo. And the reason for that, we think, is because it's allowing less disease activity. The immune system isn't as bad in the patients properly treated. Plus, we're getting away with much less steroids. So again, it's just an amazing future for lupus patients.
Wow, that makes me feel so incredibly optimistic. Just to know these new medications and to think about the teenager that's diagnosed with lupus nephritis and SLE, or a child, or someone like that. The future is so bright, and that's incredibly great news. Well, we're almost out of time, but there's a couple questions I'm going to see if we can get to. There's one question here that says, Dr. T, can you answer this question? Can you get the shingles vaccine if you are on prednisone long term? 4 different times I've been told no.
That is absolutely wrong. I don't know who told you that, but unfortunately, there's a lot of misinformation out there, to include amongst doctors and rheumatologists even. And one part of that is because there's a lot of confusing data and a lot of confusing research studies. We recommend trying to wait and give vaccinations until the prednisone dose is less than 20 milligrams a day. That's mainly because vaccines probably work better if the prednisone dose is less than 20 milligrams a day, and the lower it is, the better it is. The person might have been thinking more about the old shingles shot, which is the Zostavax, because increased doses of prednisone increase the risk of getting a live vaccine. But Shingrix is an inactivated vaccination that has no live virus in it whatsoever. And so if you're on prednisone less than 20 milligrams per day, you absolutely can and should get it, because if you're on any prednisone at all, you're at high risk of shingles. Even if you're 20 years old and you're a lupus patient and just on hydroxychloroquine, you're 3 times more likely to get shingles than an old, healthy person. That's how bad it is. It's such an important thing that on July the 26th, my birthday, the FDA approved the use of Shingrix, which is the newest and best shingle shot, in everyone who's 18 years of age and older who has an immunocompromised condition like systemic lupus erythematosus. And so I recommend that all my patients with lupus who are 18 years of age and older, no matter what, get the Shingrix shot. It's 95% effective against shingles. The downside, unfortunately, is, again, the insurance companies. Most of them, unfortunately, won't cover it, and it is an expensive vaccine, unfortunately. But it's much less expensive than if you get bad shingles. Right now, I have one patient whose arm is completely paralyzed from shingles. I have another patient who, a couple of years ago, died from shingles because it attacked her brain. And I have this one patient right now, this great guy, one of my favorite patients. He kept... I recommended Shingrix to him dozens of times, and now he's suffering from the most horrible leg pain. And now all of his family members have gotten the Shingrix shot because they see how much he's suffering. So please get your Shingrix shot.
Wow. So 18 years and older.
Yep.
Wow. Yes. Ask your doctor about that shot. I'll finish up on this last question here. When I had the antibody test, I was given the result and it was negative. I recently received the booster. Is it likely it might also show a negative result?
Yeah, so first of all, it all depends upon which antibody test was done. And just a quick story, one of my patients who's actually a very smart oncologist, he got his vaccine and then he was tested for the antibodies and was negative. He called me up on the weekend freaking out because he was afraid he didn't have a response. So I entered him into the NIH COVID vaccine trial, and they tested him for the correct antibody, which is the spike antibody response, and he had a positive response. So it all depends upon which antibody test was done and if it was a good, high-quality test or not. And so the only way you know is by having a high-quality spike antibody test result, and I would recommend doing that through a research trial where they have good, high-quality labs and not just like LabCorp Plus, which you really don't know what the quality of those are. But if you got the booster shot, you have a much higher chance of having a response. And we saw that from the Moderna trial again. Remember, if you immunosuppressed, please go to my website and look up my most recent blog, and I actually show you the numbers to include those who didn't respond at all to the second shot, but then had a significant response to the booster shot, because it is much higher.
Mm-hmm, mm-hmm. Thank you so much for that information. It's really interesting. And there are ways that you can register to be involved in these studies through the National Institute of Health, and also Johns Hopkins has a study as well. And I can post those links to those as well here after we're done. Well, it looks like we're out of time. I just want to thank you, Dr. T, again for sharing your time and your insights with us. And for those that maybe are meeting you for the first time, where can everybody find you and follow you?
I'm sorry, say that again?
Oh, for those that maybe are joining for the first time and meeting you for the first time, where can people find you, find your book, find your website, and follow you?
Yeah, so I just started my new website last October or so. It's the Lupus Encyclopedia.com. And just put your email address in the pop-up window, and I'll send out emails when I post new posts. When new research comes out or important information about lupus comes out, I try to put up posts. I've been less active recently just because of the book, but I'm going to try to get more active again. I also have a Facebook page, Lupus Encyclopedia, where I also post on there as well. And I also have a Twitter account as well. So I'm active on all of those. My current book is actually still incredibly helpful because 95% of the information in there is high quality current information, and the Lupus Encyclopedia is available on Amazon.com.
Wonderful. Thank you so much for sharing. Fantastic. Well, please everyone, make sure you share this presentation. It will be available on YouTube later today as well. And just know that we are here for you, that you are not alone, and there are resources like the Lupus Encyclopedia here that can drastically improve a lupus patient's quality of life. So thanks again, Dr. T, for your time. Take care, everyone, and stay safe. Wear your masks, social distance, wash your hands, and get the vaccine if you haven't done so already. Thanks again. We'll see you next time. Bye-bye.
Bye, Kelly. Bye, everybody. Have a good Saturday.